Good afternoon. My name is Dr. Aldomoro Burua. I work with the CAD4TB TB project. I'm embedded at the National TB and Leprosy Program in Uganda and support active TB case finding activities. So I'm here to share our experiences in optimizing the use of mobile digital X-ray with the computer-aided diagnosis at health facility and community settings, challenges and recommendations. Next slide, please. Yes, I will just give a brief background of the TB situation in Uganda. According to the WHO Global TB Report, Uganda is among the 30 high TB HIV burden countries globally. For those who may not know where Uganda is located, on the world map, Uganda is in East Africa. It's one of the countries in East Africa and in Sub-Saharan Africa as a region. So we are affected by TB, the dual pandemic of TB and HIV. So the current TB incidence that from the estimates of WHO is that we have about 200 estimated TB cases out of 100,000 people. That translates into about 82,942 estimated cases. But going by our performance as a country in the last financial year, 2019-2020, we notified about 62,000, which is about 76% of the estimated TB patients. So we are missing about 1/4 of the estimated TB patients. The country undertook a national community-based prevalence survey in 2016, and from that survey, it was revealed that about 90% of patients who sought care at health facilities were not screened for TB, and about 37% sought care at private health facilities. From the same survey, it was also realized that about half of the confirmed TB patients would be missed if symptom screening was used alone. So it was recommended that the use of chest X-ray in addition to symptom screening has potential to increase TB case detection. However, in Uganda, as a low-income country, access to X-ray services is still limited due to lack of functional X-ray equipment in many health facilities, but also high user fees in those private care providers who offer the services, and also stock out of supplies for X-ray. This is, I'm referring to the analog systems that use X-ray films. So a recent survey which was done from these facilities revealed that only 35% of hospitals had functional X-ray. That was conducted in 2017. So we have a big gap in the access to X-ray services as much as recommended. The next slide, please. So our strategic focus in the National Strategic Plan of 2021 to 2025, one of the strategic objectives is to increase the TB treatment coverage from 76% to 90% by 2024-25. And the strategic interventions include, among a number of interventions, pulled out specifically what applies to chest radiography, is that we would like to improve coverage and access to chest X-ray services by functionalizing the existing X-ray machines at hospitals, and also procure digital X-ray machines for hospitals that lack the equipment, and strengthen intra and inter-facility referrals for X-ray services. And then we also want to improve TB case finding among high-risk groups through implementing innovative targeted screening interventions using the mobile digital X-ray systems. And next, please. Yes, so I just want to introduce how we came to use digital X-ray systems with computer-aided diagnosis in the country. Through support from the Global Fund Against AIDS, Tuberculosis, and Malaria, the country acquired 5 digital X-ray systems fitted with computer-aided detection of TB, which is called CAD4TB, for automated results interpretation. This equipment, which you see on the right-hand side, we are procured in 2020, and they were placed at 5 health facilities that serve high burden districts to actively screen for tuberculosis. These X-ray machines were used specifically for TB screening for patients who are attending routine care at health facilities. But also we use them for targeted TB screening outreach in TB hotspots and in communities that are defined to be at increased risk for tuberculosis. And also there are communities that have had to reach with services. So we targeted these communities for our screening outreach activities. The next slide, please. So in our implementation arrangements, we integrated the rollout of active TB case finding toolkit. This is an intervention which we are implementing as a country to intensify tuberculosis case detection. So we integrated the rollout of the digital X-ray implementation in the active case finding toolkit activities. We trained clinicians in the use of digital X-ray and interpretation of X-ray results for TB diagnosis. As you can see on the picture, this was the first group of clinicians who were trained at the National TB Program, thanks to Delft Imaging, who supported the training of the healthcare of the clinicians. In addition, we also mentored healthcare workers on using the TB screening and diagnostic algorithm to identify eligible clients for X-ray and for clinical decision-making on TB management. If you see on the right-hand side, this is a radiologist from one of our specialist hospitals in the city. He's holding an image, an X-ray image, and he's talking to multidisciplinary teams of healthcare workers at the health facilities, trying to empower them with skills in interpretation of X-ray outputs. So these are some of the support which the national program provided at the facility level to improve capacity. Next slide, please. So to determine who is eligible for X-ray, we employed the national TB screening and diagnostic algorithm, which is on your right hand, the image on the right hand side. The steps in the screening is that for every person who comes to visit the health facility, we'll screen for TB symptoms. So we screen for cough, hemoptysis, weight loss, and all these other symptoms using the symptom screen. But if you look at the image, there's a box on the right hand side of this image shows that in addition you can have people screened using X-ray. So those who have abnormal X-ray also, even if they do not have symptoms, qualify to be presumptive TB patients. So from our algorithm, those who are found to be presumptive TB are sent for laboratory investigation. So in step 2, we separate, fast track, and send all patients for detailed history examination and laboratory examination for those who are found to be with TB symptoms or with the abnormal X-ray suggestive of tuberculosis. And then in step 3, we evaluate and decide to treat as TB or not, whereby presumptive TB patients with a positive lab test are treated for TB, and those who test negative in the laboratory are re-evaluated, and if they still remain symptomatic, they are referred for X-ray. So this is specifically referring to people who have an initial negative laboratory test that they qualify for X-ray test, X-ray examination. And if the X-ray is found to be suggestive of TB, then they are initiated on TB treatment. And step 4 is to prescribe the appropriate regimen based on the national guidelines. So this is the general TB diagnostic algorithm, which is used at the health facilities to manage tuberculosis. But now I want to specifically talk about, next slide please. I want to talk about how the X-ray screening algorithm comes in place, because you realize that we have only 5 of these equipment initial implementation at health facilities. So we had to adopt a separate algorithm specifically for those facilities that have got the digital X-ray systems at facilities for purpose of screening eligible patients. So from this image, this algorithm shows that all patients who actually seek health care will determine if they are eligible for X-ray or not. And the eligibility for X-ray is listed here. that all the outpatient attendees with no contraindication for X-ray are eligible for X-ray as a quick and reliable screening tool to exclude TB, tuberculosis disease. But you notice that at health facilities, especially the large volume facilities, there is a high client load. So it's not possible to screen everybody, much as that's what we are desired. So we had to identify the priority groups for X-ray. And these are the people living in HIV, the healthcare workers, TB contacts, prisoners, diabetic patients, minors, and refugees. So these populations, when they come to seek service at the health facility, we prioritize them for X-ray screening. And then in addition, the patients who are screened using symptoms and they found to be presumptive TB, first initially trials for a lab test, sent for a lab test. And so if the initial lab test is negative, those are the ones whom we send for X-ray. That is for those who are not in the priority groups, but they qualify to be presumptive based on symptom screen. If the initial lab test is negative, those ones are provided X-ray test. So that is how we determine who should be accessing the X-ray services. And there are people who are considered ineligible for X-ray. These include the pregnant mothers and people who had the recent exposure to X-ray, especially in the last 1 year. Unless if they have compelling indication for an X-ray, those ones were excluded from accessing the service. So in our algorithm, anyone who meets that criteria, being eligible for X-ray, especially if it's a high priority group or is a presumptive on symptom screen but had an initial negative lab test and qualifies for an X-ray, we consider the score as a threshold of 60%. So if the X-ray score is 60% or above, as by the CAD4TB percentage score, those ones qualify as presumptive cases and are referred for a laboratory test. And the preferred test we're using is GeneXpert, but in facilities where GeneXpert is not available or maybe it's not functional, we also use the microscopy for diagnosis of TB. And those who tested from the lab as positive, we are initiated on treatment as pulmonary bacterial confirmed TB cases. However, for those who tested negative and with the abnormal chest X-ray results, the clinicians further assessed these patients and they took a clinical decision to initiate treatment as a clinical diagnosed patient, depending on the presence of symptoms and also the X-ray findings. But that was left to the clinicians as per the national guidelines for TB management. Next slide, please. So this is the performance of the 5 X-ray sites that implemented the digital X-ray systems between June 2020 and August 2021. We screened a total of 5,262 individuals in this over this 1-year period. And out of these people screened, 802 had abnormal chest X-rays suggestive of TB, which is 15% of the total who were screened. And then 300 cases, TB cases were diagnosed with TB. But out of these 300, those who are bacterial confirmed were 79, while those who are clinical diagnosed were 229. This data is for both health facility screening and also community level screening. In terms of the proportion of abnormal X-rays among those screened, it was 15%. While the proportion of confirmed TB patients who are bacterial confirmed, that is 79 out of those who had suggestive X-rays is 10%. But you need to recognize that a number of the patients were diagnosed clinically based on the clinical judgment of the clinicians. So out of the 800 people who had abnormal X-rays, about 200, which is 25%, were clinically diagnosed. That's a point to note. Next slide, please. So this data is just to show you comparison of TB screening outcomes at the health facility and the community settings. So the initial data I showed you of 5,000 people screened, about half of those were screened from the health facility. You can see from the 5 health facilities, we have a total of 2,500 patients who were individuals who were screened for TB, and out of those, 19%, which is 475 of them had abnormal X-ray, which is 19%. had the suggestive X-ray, and the 410 of them had their samples examined with gene expert, and 160 TB patients were diagnosed. Out of the 160, 56 were pulmonary bacterial confirmed cases, which is 12% of those who were examined in the lab, and 104 were clinically diagnosed. So that is at the facility level. But when you look at the community level, we screened a total of 2,753 patients from all these 5 hospitals are listed here because the equipment were picked from the hospital and taken to the community. So the data from the community was reported under the hospital where the X-ray machine is placed. So we screened a total of 2,753 clients within the community settings. Out of that, 327 had abnormal X-ray, which is 12% of those who were screened. And from those, 310 had samples examined in the lab, and 148 TB patients were diagnosed. Out of the 148, 23 were bacteriologically confirmed, which is 7%, while 125 were clinically diagnosed. So from this data, we noticed that there was a higher proportion of patients with abnormal X-ray within the facility settings, which is 19%, and the yield of 12% is higher in the facility compared to the community. But the reason specifically here is because at the health facility, we are mainly dealing with high-risk patients who have come to the hospital because they are very sick and they have higher chances of having TB. So it's one of the areas that we want to make a recommendation on the sustainable use of the equipment to get TB diagnosis. Next slide, please. So my presentation was about sharing the challenges experienced and how they were managed and the recommendations. So I want to discuss the challenges along these thematic areas. There were challenges around the personnel to operate the digital X-ray machines. One thing we need to appreciate is that we do not have adequate qualified radiographers in the country, let alone X-ray machines in the country. So this equipment, when they came and the facilities where we placed them, there was basically no qualified radiologists available. Out of the 5 facilities, I think there are only 2 that had the radiographers, but the other 3 did not have. So we had to identify clinicians and train them. So if you see in this picture here, the people who were training here are actually clinicians. These are basically clinical officers, medical officers, and nurses who were imparted with skills to operate these digital X-ray machines. And in addition, we had the support from the Delft Imaging, who continue to provide monthly virtual engagement to support in case of challenges in implementation. Then the other challenge was around technical capacity in using the equipment, particularly inadequate knowledge and skills among the clinicians to interpret the X-ray images, especially where there's failure to obtain CAD4TB outputs. We need to appreciate that not all the X-ray screens we did were able to generate CAD outputs. This is something which we want to bring to attention, that I don't know if it's a technical problem, connectivity issues, but sometimes we do not get outputs for CAD4TB for some of the X-ray screens done. So in such situations, the clinicians have to interpret these images by themselves. And what we did about it is that we, of course, did training of the clinicians and also mentored them on interpretation of X-ray images to facilitate TB diagnosis. In addition, we also engaged the specialist radiologists to mentor clinicians in X-ray use so that they're able to use these services for diagnosis of TB. Next slide, please. Yeah, there are also challenges around the operations of the digital X-ray equipment. For instance, we decide that all patients screened with the X-ray need to first be confirmed in the laboratory before initiation of treatment. But most times the gene expert results are delayed to come. This is partly because, especially for the community activities where the X-ray machine, the samples have to be collected from the community and then taken to the health facility, nearby health facility for gene expert testing. some of these sites already have a lot of workload, and they're unable to manage all the samples in time. So because of this challenge, we decided to strengthen intra-facility linkages and referral patients between different departments, especially through mentorship sessions. And then we also strengthened collaboration with the nearest health facility that had the gene expert machine in conducting this TB screening outreach. Specifically, in our planning, when we plan to do a community level screening, we would have to inform the nearest gene expert site, and they also involve the health workers from these facilities, so that they know what to expect, that there are some outreaches happening and samples will be coming to the facility. That way, we're able to reduce on the time for receiving back these results. And we also involve the laboratory team at the X-ray site. So whenever we go out for community outreach, we move with the laboratory team as well, so that they can support in sample collection and testing during the outreach. The other way also we're trying to address this issue is by moving into the mobile clinics, the mobile X-ray TB clinics. Those are basically trucks with all facilities in one clinic. Already the country has has plans of acquiring mobile X-ray trucks, 2 of them, to support in this. But this is not likely to address the challenge from the other sides, so we still need to work on strengthening that. Then the other challenge is that tendency by clinicians to initiate TB treatment based on abnormal chest X-ray results before laboratory confirmation. So this is basically a sequel of the delay in getting gene expert results. So the clinicians tend to initiate treatment, and that's why in our data, there are a high number of patients who had a high clinically diagnosed patients who were initiated on treatment. So to address this issue, we disseminated the TB diagnostic algorithm at all the service delivery points, and also mentored the clinicians to follow the algorithm and ensure that they first receive laboratory confirmation before treatment is initiated. Then the other challenge is on the sensitivity of the CAD4TB to distinguish previously treated TB cases or cured TB patients and patients with active TB. If you look at the image, the upper image, this is a client who was a female, 46-year-old, had a CAD4TB score of 89%, and the expert result was negative. So this is a dilemma which we actually thought that by having a high score, the gene expert result will automatically be positive. But you notice that here, the result was negative. And there are a number of such cases. So it is just a point of emphasis for the clinicians to know that not all high CAD4TB scores necessarily mean that this is a TB case and they should initiate treatment. So we have to continue emphasizing to them to follow the algorithm and first receive the patient's laboratory result before a decision can be taken on treatment. And then the image below shows the patient who had previously treated for TB 5 years ago, and now comes back with some signs and symptoms of TB. And this X-ray image had a high score of, I cannot see very well what's below there, but it's about 90%. So someone would think this is active TB, but when you get the history of previous treatment, we don't know if this reason is due to a previous healed scar from TB or it's a new active disease. So this is an area which we want to pose for the developers of this technology to see if how sensitive is the artificial intelligence to distinguish between the healed scar and the active disease. Next slide, please. The other challenge is in recording and reporting of X-ray services. With our tools for recording X-ray services are not standardized and integrated in the national HMIS tools. We also do not have we still don't have a robust system for electronic management of X-ray data. So what we are doing about this is that we have developed a screening form for recording X-ray services, and we're using the offline data kit for reporting X-ray services utilization. But as we get more equipment in the program and also more screening utilization increasing, we needed a system to be able to manage this data properly and be able to share with the both national and international audience. One area which we are trying to look at is the screening analytics and management tool that was developed by Delft Imaging, and they sent us for one of the sent us for one computer system to pilot. So we are trying this, and if it works, we hope that we should be able to install the system for all the X-ray machines to improve on data management. Then the other challenge is on the lack of standard system for sharing X-ray results with the patients, and the lack of unique patient identifier, which may result in repeated exposure for patients who access the X-ray services. These X-ray services, the digital X-ray equipment produces digital images. So we do not, the equipment does not come with a printer, and we don't have a mechanism of sharing the output. Sometimes patients ask for their results and want to see, because they're used to carrying the X-ray films. So this has been a challenge, and we have not come up with a very substantive solution to address that. And also there are patients who have already been screened before. How do we identify these people so that we do not expose them again repeatedly? So those are things which we need the system to be able to identify and address that issue. Then there are also administrative challenges, especially to do with the approval requirements by Atomic Energy Council. Since that this equipment is a radioactive emitting device, it requires approval by our local regulatory agency, the Atomic Energy Council. But because these equipment are placed at public facilities, there are costs involved in getting licensed, and often it's a challenge for the facilities to provide this money, which is required annually for certification. And also the fact that we do not have qualified radiographers at some of the sites, we do not meet those requirements. So it's something which we need to undertake by engaging Atomic Energy Council to see how they can do waivers for the public health facilities. The next slide, please. Yeah, so lastly, the challenges around the structural challenges like X-ray equipment failure, especially the X-ray tube and HP laptop batteries. We've had these challenges with the batteries of some sites that run down and cannot be charged anymore. And yet the X-ray tube comes with only one battery, so the rendering the services non-functional. Also, the power backup systems sometimes break up; they are unable to perform their function. Then there are connectivity issues between the detector and the CAD4TB box, which leads to failure to obtain scores for some patients. These are some of the challenges with operations of the equipment, and we've tried to address these challenges through virtual support from Delft Imaging. We have normally monthly meetings to do power troubleshooting and addressing some of these gaps. If you look at the image on the side, this shows you one of our monthly logs, which with the issues identified at the different facilities and actions taken with progress to monitor. And this is an initiative Delft Imaging through the regional office in Ghana, and it has helped us a lot to functionalize our X-ray systems. Then the other challenge is about the lack of suitable space, which delayed implementation at some sites, and the safety and security equipment of the equipment was not available. We have engaged the hospital and the district management and partners to help in refurbishing the department where we can place the equipment safely. And then there are high costs for servicing and maintenance contracts for this X-ray equipment from the supplier. We also lack maintenance services locally. This equipment being new, I think we do not have local providers who can do the servicing, and yet the cost for maintenance from the supplier is a bit high. So we think that this can be addressed by building local capacity to troubleshoot and also provide the support to the X-ray sites on site to ensure that they remain functional. The next slide, please. Next slide, please. Yes, so I will conclude in that from the data that I presented, we noticed that the yield of TB from screening using digital X-ray is higher at health facilities compared to community settings, especially when used among people at increased risk for TB. We also noted that digital X-ray with CAD is applicable in settings with inadequate human resource for radiology services, as clinicians trained on the job can use the equipment. So our recommendation is that the national TB programs and partners should scale up the use of digital X-ray with the CAD for TB screening, targeting the high-risk populations to improve TB case detection. We also recommend that partners and the national programs should invest in mobile TB clinics with integrated platform for both X-ray screening and laboratory diagnosis to ensure timely diagnosis and initiation of TB treatment. We would like to recommend strengthening capacity of clinicians in use of automated TB diagnostic tools like digital X-ray with computer-aided diagnosis to address human resource gaps hindering access to radiology services for TB diagnosis. To address the issue of power and the breakdown of the batteries, we recommend that there should be provision for alternative power source for the digital X-ray systems, especially for outreach purposes. I'm aware that the supplier Delft Imaging was able to has mobile solar systems called the Mobistand, but for our equipment they were procured, I think, without these solar panels. So it's a recommendation for our national program to acquire them to be able to address the challenges of power shortage for outreach activities. And then lastly, we recommend that we should build local capacity for maintenance and servicing of the digital X-ray equipment at the country level for sustained use of the digital X-ray systems. Next slide, and I think it's my the end of my presentation. Yes, I would like to. These are next. These are just a few pictures. The next slide, please. Okay, these pictures show the activities which we've undertaken at facility and community levels. Yeah, so I would like to acknowledge the Minister of Health, National TB and Leprosy Program that supports, provide the technical support and oversight implementation, the Global Fund for supporting the procurement, acquiring this equipment, and you said the FITB project, providing the human resource to embed at the national program to support active case finding activities, Delft Imaging, district teams and health workers at this facility. The picture shows some of the challenges faced while moving out for community outreach activities in the difficult to reach regions of the country. I thank you, and back to you.